over time, as your serum pH fell, eventually your urine pH would fall because you don't have enough bicarbonate to even dump out there. So in the type 2 RTA, the urine pH can be variable. What's important are the different etiologies. Certainly one of the most common that we all see are the carbonic anhydrase inhibitors. Somebody who's taking acetazolamide, important cause of type 2 RTA. You can also get it again with amphotericin, very common, very predictable, probably have seen that. A variety of heavy metals, myeloma is an important cause, and Sjogren's syndrome is another important cause associated with type 2 RTA. The other thing that type 2 RTA may be associated with are other defects in the proximal tubule. So this can include low phosphorus, low uric acid, glycosuria, and amino acids, the COAL, C-O-A-L. Cysteine, ornithine, alanine, and lysine can all be dumped in the urine and may also be clues. So if you have a patient, again, clinical scenario with non-ANGAP acidosis, low phosphorus, low uric acid, you should immediately suspect a type 2 RTA. These patients, in general, the treatment is to give them lots of bicarbonate and correct the abnormality that way. But again, on the boards, they're looking for recognizing the RTA and doing that. The easier one to recognize is the type 4 RTA, typically seen in patients with diabetes. By far the most common cause of RTA is type 4. The most common cause of type 4 RTA are patients with diabetes. Typically they have mild renal disease, stage 2 to 3 chronic kidney disease, and hyperkalemia, non-ANGAP acidosis, but it also is seen with obstructive uropathy, and that may be a clue to a case of obstruction, where a patient comes in with obstruction, has a potassium that seems particularly out of proportion to the degree of renal failure. The creatinine is 3, it's a 78-year-old man, and the potassium is 7.5. That's a classic setup for obstructive uropathy, and on the boards, the answer would be order an ultrasound of the kidney or put in a Foley catheter, because that's what they would expect, something like that. It also occurs in a variety of interstitial diseases, including sickle cell disease, which affects the interstitium of the kidney, and you can see it in cyclosporin as another possibility. Okay, the treatment here is primarily to correct the acidosis with bicarbonate. You can also use furosemide, you can use a mineralocorticoid like Florinef. So again, a little bit easier to recognize. So the major types of RTA are shown here. The type 4, the pH is variable. It's usually less than 6. The potassium is high. That makes it very easy to recognize, typically seen with diabetes and obstruction. Type 1 RTA, pH always greater than 5.5. Potassium is low. Think of stone disease. It's been associated with hyperparathyroidism, nephrocalcinosis, and you should be able to recognize that. And then finally, there's the type 2 that we mentioned, bicarbonate wasting. pH is high, then it falls. Potassium is low. Think of Fanconi syndrome, Sjogren's, drugs, myeloma. Okay? So hopefully we've quickly demystified the RTAs. Now, let's move on to metabolic alkalosis. And again, I'm going to look at the classic ways in which these have been divided in most textbooks, because honestly, I think that's the easiest way to remind it. So for metabolic alkalosis, when you see a patient, obviously after you do your urine physical, one of the most important laboratory studies you can order is the urine chloride. And so for metabolic alkalosis, you can divide them into those that are urine chloride sensitive, which are generally volume-dependent types of metabolic alkalosis, typically seen with upper GI losses, most commonly seen with diuretics, probably the most common cause, patients taking diuretics over long periods of time. Post-hypercapnic, it can also occur, cystic fibrosis. Then we'll talk a little bit also about those that are associated with high urine chloride, and again, the types of things that are commonly seen on boards. Those that have metabolic alkalosis with no hypertension, we'll come back and talk about those. Surreptitious diuretics, you always want to keep in mind that patients may be popping pills on the side. We'll come back and talk about those associated with hypertension and high urine chloride. And then occasionally you can see rare causes. Post-code, somebody's been given a lot of bicarbonate, the serum bicarbonate's very high. Patients who have hypercalcemia that's not mediated by PTH, they actually will excrete extra hydrogen ion, and therefore the bicarb goes up. Milk alkali syndrome, patients are actually taking in bicarb. So this is the classic overall schema most books use. So let's look at some of the things that you're less familiar with or that are the rare things that we all shove in our heads before we take exams, but we want to keep in mind. Okay? So let's start with Bartter syndrome and Gittleman syndrome. These are two important causes of metabolic alkalosis. Urine chloride is high, and they're associated with normal blood pressures. And they're very, very similar. But Bartter syndrome looks like somebody who's been taking a thiazide diuretic. They have the low potassium alkalosis and normal blood pressure, but both of these disorders are associated with low magnesium. If you measure renin and aldo, they both will be high in Bartter syndrome. They excrete extra calcium in the urine, which is an important distinguishing feature between the two disorders. And because the abnormality is in the thick ascending limb of the distal tubule, again, it looks like somebody taking a thiazide. And the treatment of Bartter syndrome is primarily to give nonsteroidal anti-inflammatories and to give additional potassium. Gittleman syndrome, on the other hand, looks like somebody who's been taking loop diuretics, and the abnormality is actually in the sodium chloride transporter. This should actually be the loop, okay? And the distinguishing thing here is that in Gittleman syndrome, it also has metabolic alkalosis, normal blood pressure, low potassium, low magnesium, but in Gittleman syndrome, they actually have hypocalciuria. So that's how you can distinguish the two. And so that would be the important feature. And in Gittleman syndrome, you need to replace the magnesium and potassium, but you can sometimes give them amiloride or spironolactone as treatment. Okay? So if we compare the two, the onset of Bartter syndrome, there is an infantile variety that can begin very early, or even in childhood.